discuss about some specific aspects at the end, and I'm happy to answer questions at the end, or you can interrupt me, whatever you prefer. So for those who don't know me, I'm a stroke neurologist. I practice, in Toronto. I was born in Argentina, and and devoted my career to stroke care. I'm a scientist also. I'm interested. I included my academic interest, and also I've been interested also in how to deliver digital contents in terms of medical education. What I would like to cover today is about, some specific aspect of cerebral venous thrombosis, and I prepare an outline for you, and we will go through that. But again, I will try to go fast in those slides when the information is already available, and I share already my slides for you to have it as a handout. Questions, just feel free to ask, okay? These are the objectives for today: to learn about the clinical presentation, epidemiology of cerebral venous thrombosis, to identify the most common risk factors, and to learn about the diagnosis and management of cerebral venous thrombosis. Part of this presentation was done at the International Stroke Conference this year, okay? So let's get started with something about learning. So this is mostly about a reflection for you about how we learn in medicine. And for example, the different, those who are invested in, doing some research, including pharmaceutical companies, they have to, conduct many, many trials until one out of thousands of molecules maybe come to the market. And today we are going to have a discussion about some specific areas that we don't have a strong evidence. So what to do under uncertainty? That will be probably a topic for another time, though. So let's get started with we'll talk about epidemiology, clinical presentation, and risk factors, and an update given this presentation or the guidelines. Let's get started with two illustrative cases, okay? Case number one is someone with history, 29-year-old woman, previously healthy, query about migraine headaches, but essentially in June 2010, she presented with a foot surgery. She had a foot surgery after having a cut and developed a DVT. And after having the deep venous thrombosis, she developed a pulmonary embolism. In November 2017, she underwent, she had a pregnancy, she had a C-section, and developed a wall abdominal hematoma and the second pulmonary embolism. Number one, this is not about, again, is someone at high risk of thromboembolic events, but again, no CVT. The second one is a 54-year-old woman that after having a fall, she had a gastroenteritis apparently, and then she developed a fall, and it was she had a deep venous thrombosis. And it's not entirely clear whether or not she had a pulmonary embolism. And in the CT scan as part of the follow-up fall, it was found to have a right transverse sinus thrombosis, and she was started on oral anticoagulation therapy anyway. So the first one, if you could guess, is Serena Williams is the story. The second that we don't have much more information is still confidential. It's about Hillary Clinton, about what happened years ago. So that's why I think that these are popular figures in which help to move the field forward to understand or to increase the public awareness about some specific thrombotic conditions as well as cerebral venous thrombosis. And that's why I'm bringing this up. So in terms of epidemiology, again, cerebral venous thrombosis is a very uncommon cause of stroke. It accounts for usually 1% of people who had an stroke. So it's a very relatively uncommon, primarily occurring in young individuals, those women at reproductive age, and those who have a tendency or history for forming some clots. It was not well recognized initially, and we will discuss about why. And the recurrency when you have a venous thromboembolism is 1 to 4% per year, and for cerebral venous thrombosis is relatively low. It's around 1% per year, roughly. In the graph on the right side, you can appreciate that, the venous system, the frequency of having different sinuses being affected. The most common by far is usually the transverse sinus or the superior sagittal sinus, and multiple sinuses could be affected in up to 50%, okay? So what is the most common clinical presentation? By far, over 90% of patients present with headaches, and usually persistent headaches. Some people may call insidious headaches. Only 20 to 50% may have some focal neurological deficit, usually associated with an intracerebral hemorrhage or a venous infarction. Seizures may occur in 20 to 40%, more common in children. And then there could be some other symptoms associated with intracranial pressure, as highlighted below, and less than 5% of people in the largest registry presented with subarachnoid hemorrhage or thunderclap headache. So it's not a very common cause of thunderclap headache of subarachnoid hemorrhage, okay? But it's a consideration when you don't have a clear diagnosis. So the problem is here is the elephant in the room. And the example is we are having so many common symptoms for people presenting to the emergency department, such as headaches or a focal deficit or seizures, but only a small proportion of them will have a cerebral venous thrombosis. So how to tease out those who really have a cerebral venous thrombosis from those who may have headaches secondary to multiple causes or migraines, etc. So this is part of the consideration, and that's why some people are, in terms of approaching the problem, is that this is like an iceberg tip. So the CVT symptoms represent a small proportion of presentations, when in fact the most common general symptoms presented to the emergency department are by far much more common than cerebral venous thrombosis. And I think that this is important to highlight, and we will come back to that later on. So what are the most common predisposing factors? So some people have, divided between transient and chronic risk factors. So transient, and this is important because in terms of the management, one thing is a transient and versus a chronic phenomenon. Transient and provoke, for example, so the hypercoagulable state associated with the, oral contraceptives or pregnancy, those are some good examples that when you remove the trigger or the potential trigger, the risk may go down. So these are some of the examples. I highlighted also some other risk factors associated with cerebral venous thrombosis that were identified recently. and it's usually being obesity that could be synergistic effect with other vascular factors or with other factors, sorry, COVID-19 and mask. Basically cerebral venous thrombosis that could be associated with a hypercoagulable state associated with COVID, and a new entity after 2021 was vaccine-induced thrombotic thrombocytopenia, and we will talk a little bit more about that a little bit later. Let's go back one question and tell me if any questions so far, or can I move on, John?
Yeah, keep going. Thank you.
Okay, good. So how about the diagnosis and management? So in terms of diagnosis, vascular imaging are the most important key points. To get starting from the end, an MRI and an MRV are probably the most sensitive tests to do it, to make a diagnosis of cerebral venous thrombosis, probably more sensitive than CT and CT venogram. Again, I will mention some of the important examples that are helpful for the diagnosis of cerebral venous thrombosis, especially when you have no limited access to sophisticated MRI sequences or techniques. So one that has been identified is the panel number A, is the cashew sign. And as you can see here is like these little dots or like commas that you can appreciate like it will be like a cashew nut. Something similar is the hyperattenuation of some of the sinuses, especially when in the transverse sinus, something similar in the panel B. And then you can see the cord sign. The cord sign is an example that you can see the thrombosed vein, especially when it's affecting the cortex. And of course, you can see the cashew sign here in the last one that I highlighted, and also some intracerebral hemorrhage. The CT scan, again, the sensitivity is 0.79 and the specificity is 0.9, so not bad. But again, you know, there are more sophisticated techniques that we could do. So moving on to the MRI of the brain. So the MRI of the brain, it relies also on the transformation of the signal with the evolution of the hematoma. So this is very important because it may not be that straightforward. What I'm showing to you today is something that is relatively easy to appreciate, but again, it's not always that easy when you are not very familiar with those brain imaging. So the first one is essentially when you do a gradient echo or susceptibility images MRI. Sorry, hello? Are we good?
Yep, we're good.
Okay, so this is one of the examples that I highlighted here in a parasagittal sign that you can appreciate, you know, the occlusion of the of one of the sinuses. You can appreciate bilateral thalamic infarct, most commonly seen in children, so venous infarctions related with internal vein thrombosis, some intracerebral hemorrhages that you can appreciate also in the panel B and venous infarctions that you can see. The contrast enhanced T1, and I will explain the differences in the next slide. You can appreciate the clot sitting in the superior sagittal sinus identified by the arrow, or the lack of opacification in an MRV, as you can appreciate here in the arrow in the next panel. So the sensitivity of the MRI is 0.82 and the specificity 0.92, not bad, as you can appreciate, okay? So 3 examples of different contrast techniques. The phase contrast MRV is one of the strategies that you can appreciate, but when you compare phase contrast that contrast enhanced MRV, meaning that the patient is receiving some contrast, or the subtraction MRV, you can appreciate the difference in the quality of the pictures and what you can appreciate. So this is in the same patient, three comparison of three different type of venous imaging, and you can appreciate how easy is identified here in the contrast enhanced MRV, the occluded sinus and engorgement of the some cortical veins, something similar here in the subtraction MRV. The problem with the phase contrast MRV that says contrast, but it's not receiving contrast. So that's a problem because it may lead to several artifacts. So that's an important consideration. So in summary, some points to remember. So the CT venogram and the MR venogram are the optimal tests. So again, when you are trying to identify superficial and deep cerebral venous thrombosis, so it has lower sensitivity than the MRI. So the CTV is have a lower sensitivity for superficial and deep venous thrombosis. So the contrast enhanced MRV, it may help to the detection of the thrombus and also provide characterization when you can see a slow flow or hypoplastic sinuses. Remember, this is very important, people. There are a lot of anatomic variants. So some radiologists report a hypoplastic sinus or narrowing of a sinus. But the important difference here is to identify, remember, not atretic sinus or hypoplastic, is occlusive versus non-occlusive. The key word for making decisions is occlusive versus non-occlusive. We may undergo to a CT venogram being asymptomatic and have a narrowing or an atretic sinus, and it doesn't have any clinical significance. So that's why I'm emphasizing this concept, okay? And remember, some specific techniques, contrast enhanced MRV, gradient echo, or SWI may help to identify cortical venous thrombosis or with the SWI with some smaller hemorrhages. So this is the algorithm that we have proposed initially in the American Heart Association guidelines in 2011, and then with some minor modifications has been updated more recently in the publication from February this year. So at the end of the day, we discuss about the clinical suspicious, how to identify or use brain imaging, and the question will be now is about what will be the management or treatment. And again, we also discuss about what are the most common predisposing factors that by far are, affecting young women in reproductive age, usually associated with some predisposing factors, including oral contraceptives, pregnancy, etc. Okay, there has been other factors that I would suggest that you go through because the list is pretty long, and some are relatively commonly seen by internal medicine. For example, someone who might be with an inflammatory condition such as, inflammatory bowel disease that may predispose to cerebral venous thrombosis. So this is essentially the management. The recommended treatment once you make a diagnosis of cerebral venous thrombosis is subcutaneous low molecular heparin. Some people use unfractionated intravenous heparin. Again, the guidelines usually recommend low molecular weight heparin instead of over unfractionated heparin. And again, the question is practical to be used? And usually, again, you don't require to monitor, patients whether you are on the appropriate dose or not. It's an open discussion about that. So the question is what happens when the patients have a progressive neurological deterioration despite anticoagulation therapy? or when you have someone who may be, in coma, or that may not have enough time to be able to work and to help prevent the progression of the clot, then this opens to different strategies. And the different strategies could be intrasinus thrombolysis or intrasinus endovascular thrombectomy, or as a life-saving procedure, the compressive craniectomy for large venous infarctions. This is important because it's unpredictable, and some patients, even with the cortical vein thrombosis, may evolve with some progressive neurological deterioration. So, and I have several patients on that, young individuals who, after the compressive craniectomy, are, completely independent. Remember, this is not the compressive craniectomy for patients with an ischemic stroke. The prognosis is different, and we are talking about the rare causes or the rare situations in which some individuals with cortical vein thrombosis or cerebral venous thrombosis require a compressive craniectomy for a venous, not for an arterial infarction. Finally, is discussing about the duration of the anticoagulation therapy. So how long should we anticoagulate patients? Again, it's an open discussion. When this is something that is transient and provoked, so examples, if a patient was exposed to a trauma, if the patient was exposed to oral contraceptives, or the transient hypercoagulable state associated with the pregnancy or puerperium, then it's something that could eventually resolve in anticoagulation therapy for a short period of time, 3 to 6 months. For patients who may have an underlying thrombophilia or other conditions that are usually not resolving, non-transient, then lifelong anticoagulation is recommended. When in between, some people keep patients on anticoagulation therapy for 12 months. An important concept that the panel was in agreement is that some people use the strategy of repeating venous imaging to guide the duration of anticoagulation. Even when there is a rationale behind and it makes sense, this is not supported by the evidence, okay? So at the end of the day, if you are asking a patient that you are going to repeat the brain imaging or the vascular imaging to make a decision about the anticoagulation therapy, remember that this is not based on evidence, at least not strong evidence or recommended by the contemporary guidelines. So what's the prognosis? The great majority of patients do well. 80 to 90% of patients, I would say over 80%, achieve functional independence and no major issues. But more recently has been described about chronic headaches or cognitive concerns, especially for those who may have, especially involved the deep venous system or intraventricular hemorrhage as a consequence of an intracranial hypertension, intravenous pressure. So those are some of the examples of chronic, epilepsy. Dural arteriovenous fistula could be a cause or a complication of cerebral venous thrombosis, and it has been recognized in those regards. So special populations, I think that we would like to cover some aspect in terms of cerebral venous thrombosis in the pediatric population during pregnancy and puerperium and vaccine-induced cerebral venous thrombosis. The pediatric population, most commonly seen in neonates, usually associated with hypoxia, dehydration, and trauma. The dehydration is one of the concepts that has been more recognized, especially with the weather or the climate changes. People going into, hiking at high temperatures and being dehydrated. I have seen a few patients who have there is no other cause for the cerebral venous thrombosis other than dehydration and perhaps predisposed by other other transient phenomenon or factors. Again, I mentioned about that 1 in 4 children may develop epilepsy, and that's an important consideration. In terms of pregnancy and puerperium, usually it's in the 3rd trimester and the first 6 weeks after the postpartum. C-sections are associated with higher risk because of the higher risk of prothrombotic events. Remember that vitamin K antagonists are contraindicated. So unfortunately, the only way is using low molecular weight heparin as the drug of choice. And some people may require prophylaxis for high-risk pregnancies or for someone who might have had a cerebral venous thrombosis in the past. Remember, as part of the counseling, a previous history of cerebral venous thrombosis during the pregnancy is not a contraindication for future pregnancies. This is very important, okay, for counseling. Finally, vaccine-induced, again, is something very similar to HIT or heparin-induced thrombocytopenia. The difference is that you not only identify thrombocytopenia, you have the exposure to the vaccines and usually related with the adenovirus-based vaccines. And usually you can test for PF4, and that's something that, you know, it can help you to make the diagnosis. And I included the treatment there with IVIG and avoidance of heparin-related products, okay? The guidelines, the recommended guidelines were published by Karen and our group in 2021. I included the reference just in case. So, in summary, as a way of summarizing, so we discussed about what to do, what are the most common symptoms associated with cerebral venous thrombosis, headaches, that you have to have a high level of suspicion because among all patients that you may have with similar neurological symptoms of cerebral venous thrombosis, only a small fraction will have a cerebral venous thrombosis. So it's important that you avoid missing the appropriate investigation when you are assessing someone in the emergency department. Consider the new risk factors. I mentioned the obesity, COVID-19, and the exposure to the vaccine. And remember about the most sensitive test to do to make the diagnosis: MRI, MRV, and CTV. Those are the most, you know, important considerations. I also mentioned in terms of management and treatment, low molecular heparin is preferred. Again, some people has been used DOACs, but the evidence, the trials were stopped for low recruitment. Again, in the guidelines, in the recommendation, DOAC seems to be a reasonable and safe option, and that's what we are trying to do before discharging patients for patients admitted with cerebral venous thrombosis, unless there is a contraindication. CT venogram and MRV, again, it's unclear if that could help, you know, guide the duration of anticoagulation therapy. The compressive surgery is considered for patients with progressive neurological deterioration despite, you know, anticoagulation therapy. There is a low evidence for that. Endovascular thrombectomy or intrasinus thrombectomy is also reserved for a progressive neurological deterioration on patients who has been in coma. And the challenge is there has been some adverse events associated with endovascular thrombectomy or intrasinus thrombectomy. And one of the considerations is, again, it could be risky. It's not recommended for as a standard practice. And again, we usually do an expert management, meaning that I usually involve and hematologists and of course internal medicine. In my view, a hematologist is very important unless you are living in a rural area, but a consultation eventually would be necessary or important. So the last 5 minutes, if I may, I'd like to have a discussion about how to avoid, you know, missing the diagnosis. And I don't know, John, Should I open for questions or should I continue? I have 3 more slides, I believe.
I think I would finish and then we'll take questions.
Perfect. Okay. So as you know, 20 to 30% of patients may be initially missed in the emergency department. It's one of the common reasons for medical legal concerns. And, you know, in previous registries, the time from the symptoms onset until the diagnosis, it was no less than 1 to 2 weeks. So that's a problem. And some patients may progress in 48 hours to have, you know, a progressive neurological deterioration and having a bad outcome. So this is why this is so important. The second important concept is something related with the previous publication in neurology a few years ago. So what the authors identified, it was they did a meta-analysis, including 26 studies and over 15,000 patients about what were the factors most commonly associated with a misdiagnosis, okay? And what they found essentially is that when symptoms are milder or non-specific, and we are talking about headaches or seizures or dizziness in these cases, okay, or transient symptoms, they were more likely to be misdiagnosed, so not making a diagnosis. So let's put in a different way. So when you hear someone that is, you know, having some symptoms that are mild, we feel, you know, what the concept that is, we have a sense of false reassurance is related with our internal biases and beliefs that feels that, oh, you probably are going to get better, but the problem is it put us at risk of missing a diagnosis. And I'm not talking about cerebral venous thrombosis here. This could apply to other neurological conditions or to other type of strokes. So how do we learn? I usually do workshops about decision making or about how we identify some specific biases and how we can improve our way of thinking and making a diagnosis and avoid medical errors. So we learn in medicine about pattern recognition. So again, I'm giving you the pattern recognition. When you are seeing someone who is young, at childbearing age, who that may be at a high risk of having a thrombotic event or during the puerperium. So that's a pattern. So the question is, should we order CTV to anyone in those that fulfill that criteria when presenting with headache, seizures, or any other more typical symptoms? So this is one of the concepts that is important, and probably most patients who presented to the emergency department and ended up in a medical legal complaint, a pattern recognition will save the life of many and the money for many colleagues. Another effective strategy, I'm talking here about effective strategies to make a diagnosis and to avoid medical errors, okay? The second is a checklist. It's a proven strategy to be able to avoid or narrow down the diagnosis. It's effective and proven effective, published in JAMA in 2015, in which residents were exposed to different checklists, and they were able, and cognitive reflection, that's the other cognitive strategy, that was improved the diagnosis by 2 times compared to those who didn't use the checklist or cognitive reflection. Finally, the application of the traffic light system when you have an awareness or a risk catching strategy that is coupled with an action has been proven to be effective. We show that the traffic light system was one of the interventions that decreased the risk of therapeutic inertia in the diagnosis of multiple sclerosis, and has been also used for other conditions, that when you illustrators showed a doctor that these are like red flags, if you want, and this red flag put patients at higher risk and is associated with an action. When you couple that, That has been associated with 70% reduction in therapeutic inertia and avoiding medical errors. So these are some of the examples that I just wanted to share with you. And again, this is the pattern recognition, some of the examples or strategies. Another pattern that we didn't mention, but someone in their 60s, 70s with a diagnosis of cancer, for example, that might be also a pattern recognition for someone presented with headaches or seizures, of course. So this is the example that I provided in terms of the traffic light system, in this case, in multiple sclerosis, so for example, some patients develop clinical and radiological evidence of a relapse or radiological activity that is usually associated with a bad prognosis or poor prognosis, and that should trigger the primary care provider or the neurologist to escalate or intensify treatment and avoid the status quo. And again, the field of multiple sclerosis has evolved, and you don't need even both clinical and radiological activity to escalate treatment nowadays. And I think that I will stop here, and thank you very much for your attention. And I will conclude quoting Benjamin Franklin that says, "Tell me and I forget, teach me and I remember, and involve me and I learn." Thank you very much for your attention.
Thanks so much, Gustavo. This is great, and plenty of time for questions. I think that I know Reza Baruz from UT San Antonio I think was raising his hand a couple of times. Reza, are you there to ask your question? He may have dropped off. There are a couple of questions in the chat.
Sure.
Actually, so there's Dr. Sidorov from Oklahoma. He's got a question for you.
Sure.
Hey, how are you? So I have a question. So, for example, if patient was diagnosed with CVT and was anticoagulated, say, for 6 months and doing quite good, a repeat imaging show that the clot persists and it really did not change at all. Is there any benefit to continue anticoagulation past 6 months?
It's a great question, actually, Evgeny. The question at the end of the day will be, what's the cause of the cerebral venous thrombosis? And this is a problem, actually, but because that would guide the treatment. If you believe, and I tell you what happened, there are clear-cut case presentations or situations in which you would definitely anticoagulate 3 or 6 months, no more than that. And some that are obvious, a thrombophilia, it's lifelong anticoagulation so far, okay? The question is in between. So I tell you, some of the hematologists that I work with, for those patients who have an undiagnosed etiology but presume systemic thrombotic event, then they prefer to keep the anticoagulation longer. Whether this is lifelong or not, that's a different story, but longer. Did I answer your question? I know it's
well, yeah, kind of.
So the question is also approaching the risk. So let me give you an example, and this is a test for you, okay? Suppose that I ask you, I will give you some, medication that may put you at risk of having a bleeding, a GI bleeding, okay? The risk of bleeding is very low, but still there might be 1 in 1,000. Some people are very risk averse and they don't want to take anything. Okay, it depends on how you present the information. And now I present the information in a different way. Look, you have a cerebral venous thrombosis, a clot in the brain. You recover very well, but we don't know the cause. So you transmit your uncertainty to the patient. And how people deal with uncertainty? Doctor, I don't want to have this anymore. So people end up accepting or taking the anticoagulation no matter what. So we are not talking about evidence here. We are talking about what's your approach to risk perception and your risk perception. That's a problem.
So this is Gustavo's a major area of expertise, a different area for and economical decisions. This is wonderful. But there's lots more questions, so we'll keep going. There's a couple of questions in some areas about atresia and just thinking about risk overall. So are there patients with some grade of a venous atretic findings, but without occlusion? Are there candidates to any interventional procedure? So in order to prevent a venous thrombosis in the future?
I have to make a disclosure here, a bias. I'm biased against those procedures because in medicine it causes harm. A good example it was the opening of the the jugular vein for the diagnosis
MS.
of MS. So remember, we all have anatomic variants and atretic sinuses, and the question is, does it need to be treated? I haven't seen the evidence to support that personally. Okay, so I don't think so. But again, you may interview an interventional radiologist who is a neurosurgeon and will convince you that they did the angioplasty and patients got better, the headaches or whatever. And so I'm not sure I have the right answer because I'm biased against.
Now the question, do patients with vaccine-induced the thrombocytopenia, do they need long-term steroids?
That's a great question. Not that I'm aware of. I have several patients and they are not taking steroids long term. It's a short term, usually taper after the initial diagnosis. And the hematologist usually checks for PF4. And when the PF4 goes down, they usually don't continue the steroids.
Now the question was the issue of anticoagulation versus antiplatelet. Is there any evidence comparing one versus the other, both for asymptomatic as well as for asymptomatic CVT as well as ones with partial occlusions?
Yeah. So let me go back to the discussion. I've been part of the panel, the American Heart Association, and be part of the Cerebral Venous Thrombosis Consortium that is based in Netherlands, okay? There is a problem here. The problem is, do we have evidence that antiplatelet agents work for venous thrombosis? I'm not a hematologist, full disclosure. So if you look at the guidelines for the management of DVT and pulmonary embolism, there is evidence that aspirin or antiplatelet, but specifically aspirin, may be beneficial for deep venous thrombosis long term. We do not recommend aspirin for partial narrowing of the sinuses or partial, recanalization. Again, this is a difference in practice. Many opinion leaders are against using aspirin long term for patients with cerebral venous thrombosis. And the argument was, and again, it's not written, but at least it's not reflected in the American Heart Guidelines. In the European, I think that they mentioned something. They are waiting more about the side effects associated long term of antiplatelets for young individuals that you are expecting that they will remain on aspirin for 30, 40 or more years. So that's their concern. On the other hand, I have the tendency that when some patients are more in the long term, to discontinue, once you discontinue anticoagulation therapy, I use aspirin. Whether this is evidence-based or not is probably more psychological and transpolating the results for deep venous thrombosis into the cerebral venous thrombosis literature. But now the emotional concept is, you are prescribing a treatment, anticoagulation therapy. You hold the hand of the patient tight with anticoagulation for a period of time. And suddenly you say, you know what? You complete 3 months, 6 months, 1 year. Now I'm not holding your hand anymore. Some people, I know that this may not sound very academic, but anyway, some people may feel that, now they no longer having a treatment. So there is evidence base and there is an emotional, concept that in my view is supporting, even when the evidence is not strong and is extrapolating for DVT.
Okay, Gustavo, if you can keep going, we've got a lot more. Playing on the whole antiplatelet anticoagulation, for a case in which somebody has an unprovoked venous sinus thrombosis, and there's a negative workup, and then they recover after anticoagulation, do you see that they then need to be put on antiplatelets after that? And for how long?
I do. I don't know whether this is, again, some people may disagree, especially from Europe. They may disagree with long-term aspirin or antiplatelet therapy. Just to make sure that there is no discussion about anticoagulation versus antiplatelet therapy in the acute phase of or subacute phase of cerebral venous thrombosis. The treatment is anticoagulation therapy, okay? No question, no doubt, it's clear. The question is what you do after. After, you complete the treatment 3, 6 months or 1 year, depending on the condition, okay? So that's essentially the difference. Some people under uncertainty continue on anticoagulation therapy, and I'll give you an example. I've seen now a 63-year-old woman who had the first episode of cerebral venous thrombosis 10 years ago. She was initially on anticoagulation therapy. All workup was negative. She had recurrent, and in addition, she had migraines, which make the situation more complicated. She had recurrent, brain imaging and vascular imaging, all clear. And suddenly, I think that she has a sinus infection, developed headaches, repeated CT venogram, and she had a massive thrombosis. And she was re-anticoagulated. And again, after 10 years of being on aspirin, okay? So now the question was, of course, the hematologist, even all workup was again negative. So the question is, she's lifelong anticoagulation therapy. Second thrombotic event, not proven etiology. How long or how many times are we going to play the game? When I said play the game, I'm trying to make it, in a funny way, not because we are playing a game, of course.
So you would do lifelong antiplatelet in the person who had the unprovoked?
Well, I tell them, it's a good question. I tell them that this is not evidence-based, but probably for not less than 6 months. Yes, I do. But I can tell you, there will be some people, if we are having the opportunity, to those who wrote the European guidelines for the management of cerebral venous thrombosis, among all the panel, only one use aspirin. The rest of the panel is against. It's not that they are. I was, as the chair of I can confess, the American Heart Guidelines, I was forced, they twist my arm that we have to remove aspirin as a potential consideration for life, not lifelong, even continue with aspirin after anticoagulation therapy.
Okay,
So,
well,
disclosure.
All right. Well, Ty, who's at UT Southwestern, what a great question you just raised there. A lot of discussion.
Great question.
Okay. So moving on to a completely different area. So Ali Caro, who's at HCA Healthcare here in Houston. So he's asking, so would you use the same treatment for CVT that's caused by a trauma, meaning like as an example, a skull fracture? And would you do the same duration?
So I love that question. Excellent question. So, we are a trauma center here. And I came into that question very often. And actually, I'm very concerned. Cerebral venous thrombosis is straightforward when you have especially a provoked event or unprovoked, but you identify the cause, okay? So the problem with trauma is that all the trials, all the discussion that we were having today was not related or proven by patients who develop cerebral venous thrombosis triggered by a trauma. I remember having a discussion and I consulted Dr. Ferro from Portugal. He's probably the father of cerebral venous thrombosis. The initial large registry were driven by him and someone from Mexico. And when I asked him about what to do with the same question you are asking me, he said, Gustavo, we don't have evidence. We don't know what to do. And I can tell you, I don't know what to do. And I can tell you, I will pose the question and answer the question in a practical way. Most patients with multi-trauma usually have a contraindication for anticoagulation therapy unless you have a very strong cause. You have a clot sitting in the heart, or you have, yes, a massive cerebral venous thrombosis that you may wonder whether the cerebral venous thrombosis occurred before the trauma, okay? So the question usually is, most people are having a transient or a small segment of narrowing or non-occlusive. I would say that 80% of patients that we are being called by the trauma because of question mark cerebral venous thrombosis is an atretic sinus or a non-occlusive. And I don't anticoagulate those patients. I don't support anticoagulation. Hope I answered that question. But it's still an open chapter in the medical history of cerebral venous thrombosis related with trauma. And I don't think that we have a strong evidence in one way or the other.
Okay, thank you. Wonderful. All right, just trying to get us through a few more.
Sure.
So when surgical decompression is being considered, wondering about the risk of taking the patient off anticoagulation for the surgery. How do you mitigate this risk?
It's a great question. Unfortunately, again, remember, you already have a patient that if you are taking someone to the OR, meaning that the most recommended treatment didn't work. Remember, we are talking about anticoagulation therapy. It's not a thrombolytic agent. It's not going to anticoagulation, even heparin. It's not going to disrupt the clot in 1 hour. It's trying to prevent the progression of the clot and the symptoms directly related with the clot and progression and the symptom that could be caused by venous hypertension and secondary causes, for the venous thrombosis. So secondary consequences, not causes, sorry, consequences. So at the end of the day, you already have a patient that may require a more aggressive treatment because the standard of care, level 1, it didn't work. Or anticoagulation therapy, you are not expecting that anticoagulation therapy will do anything. Who I'm referring to very specifically, someone who came in coma and you diagnosed with cerebral venous thrombosis, you can anticoagulate, but it's not going to do anything differently. So you may need to take the patient to the OR or the interventional radiologist, either for intrasinus thrombolysis or intrasinus thrombectomy.
Okay, very good.
And again, the craniectomy, unfortunately, once you are exposed, the transient suppression of anticoagulation therapy, unfortunately, you are going to a life-saving procedure. It's the family who may need to take the risk. I usually involve the hematologist to initiate anticoagulation therapy. The sooner, the better. Everybody would agree that 48 hours after is safe. The question is what to do with someone with cerebral venous thrombosis in the initial post-operative stage. That's the question. Okay, and again, unfortunately, there is no specific recommendation that I could provide.
Okay, another question. So now with cases and various different types of scenarios. So a 32-year-old woman with a history of a gastric bypass presents with acute pancreatitis, and the course is complicated by developing a deep venous thrombosis in the arm, and is started on Eliquis. The patient's then discharged and then comes back with a headache, is found to have a cerebral venous thrombosis. So question is, what do you think the etiology is of the cerebral venous thrombosis, and what do you think about long-term anticoagulation at that point?
So it's a great question. So the first thing is you need to identify is whether this is a prothrombotic state while someone was receiving full anticoagulation therapy. When you mention Eliquis, the question is full dose. Was the patient receiving full dose or the patient received 2.5 BID? It's not the same. There is evidence that the risk of having a thrombotic event in someone with subtherapeutic anticoagulation on Eliquis may have 5 times more likely to develop a thrombotic event, or in this case, I'm referring to ischemic strokes, okay? When you are in a subtherapeutic dose. So this is important consideration. But assuming that yes, this is someone who was fully anticoagulated, then my next question is are we missing anything? Why someone is fully anticoagulated for a DVT and develops cerebral venous thrombosis? The answers, or my answer, will be number one, someone is having a prothrombotic state related with an underlying malignancy that we are missing, number one. Number two is, well, it could be a failure. The effectiveness of oral anticoagulants for, a thrombotic event are not 100%. It may happen. But if I will be the patient, and the question is, you assume now that you fail the initial anticoagulation therapy, switching from Eliquis to another oral anticoagulant, or consideration for prolonged anticoagulation therapy after completing a second panel of diagnosis, okay, for the etiology, that's what I would think about. Remember, an important opening bracket, when you are making a diagnosis of a thrombophilia, it's not enough to have one panel or one time. You need to repeat the test, anticardiolipins antibodies, beta 2, and lupus anticoagulant at least 2 weeks after. So remember that this is, again, you need 2 sets of negative results before you can say that there was no etiology. It's a complicated situation.
Okay, well, there's another one. I know some of my colleagues were waiting to hear what your thoughts are. It seems like this is a challenging case. From my colleagues up at the Woodlands at Memorial Hermann, I guess they have a patient right now, somebody who's quite sick, bleeding gums, petechia. They're positive for paravirus, positive for CMV, 3 antibodies positive for antiphospholipid antibody, thinking secondary to idiopathic thrombocytopenia. And the patient's received a lot of aggressive therapy, including IVIG. HIV is negative, bone marrow biopsy is negative. The patient has subarachnoid hemorrhage and a big burden of cerebral venous thrombosis, and the platelets are, unfortunately, 10,000. Could you offer any thoughts on management?
So corticosteroids were also given, I assume, as part of the HIT treatment.
Yes.
I don't think that I have an answer for that. I don't think that there is a winning situation here, given the concomitant combination of, thrombosis and bleeding. That's a big problem. So the other differential will be, in my mind, DIC. So, but I believe that the hematology will be on top and would lead the management. I don't have any specific recommendation, unfortunately. The patient may die. The question is, what will be the cause of death? Whether this is thrombosis or a bleeding. I'm sorry.
It's a very tough case. Yeah. So this is another very interesting question. So for those that monitor heparin anticoagulation with anti-10A protocols, some centers do this, some do not. So if one was giving unfractionated heparin for CVT, do you utilize the full dose DVT protocol? For the anti-10A protocol, that is a range of 0.3 to 0.7 versus a low dose, protocol such as 0.3 to 0.5, which is often just given for stroke patients. If this was, would you have any advice on if this was a patient who had a CVT without any intracranial hemorrhage?
It's a great question. I'm facing that question every time I'm on service and having a discussion with the residents, because some people don't understand what you are trying to do. So the principles, the therapeutic principles. So let me give you an example. And the example is you are having someone, imagine that a family member of you, for those who are asking that question, is having a cerebral venous thrombosis. You know that the most effective treatment so far is anticoagulation therapy, whether heparin, low molecular weight, or unfractionate. When do you want to have the patient anticoagulated? Would you like to wait? Would you like to wait 5 days until you are therapeutic? The answer is no way. You want to have the patient anticoagulated once you make the diagnosis. There has been medical legal complaints in the US that I was, part advising of delay of initiating anticoagulation therapy. You don't want that, especially when our society is claiming and making more complaints and is more informed. So we have here in Canada the low or high nomogram for unfractionated heparin. The low nomogram is a joke, because at the end of the day, you are going to be in 48 hours identifying if the patient is not fully anticoagulated. So you have to give the bolus 5,000 units, and you have to have a high nomogram. No question. The same would happen if you decide to anticoagulate someone with a dissection. Why to wait? You don't have to wait. Again, it's a different scenario, because the question then will be a different discussion about the benefit of anticoagulation for dissection. But once you make a decision that someone needs to be on anticoagulation therapy, then you need bolus and high nomogram. That's it. There is no discussion here. Especially when there is no bleeding, especially when there is no bleeding specifically. So it's not a discussion. So it's whether you have the patient anticoagulated or not. You may argue that, well, I'm concerned because this is a frail 90 years old who is 60 kilograms, and I don't want to give the full dose. Okay, but the question is, what's your APTT target? So my APTT target in that case will be double.
Wow.
Okay,
Yeah.
so if I'm starting with, let's say 35, I like to be that no less than 60. So once we make a decision, we steer towards that decision. It's a common problem everywhere.
All right. Well, there's still many people. It's a couple more, and still people. We still have them on. So if you're still good for a few more, Gustavo.
Of course.
Okay.
Again, I want to do another reminder of my disclosure. I'm not a hematologist. I may have strong opinions, but I'm not a hematologist. I'm providing my perspective as a stroke neurologist, and I always consult a hematologist, because in my view is co-management, or at least is the treatment long-term should be driven by the hematologist. I'm not an expert in thrombosis anyway.
So Ty brings up another interesting question. So if in the case of a meningitis associated with cerebral venous thrombosis, will you consider the risk of hemorrhage from infection if on anticoagulant?
Okay. It's a good point. So sepsis, it reminds me, sepsis was, and again, I would mimic meningitis and sepsis at the end of the day is part of the same pathogenic mechanism. Is an independent predictor of, thrombosis, cerebral venous thrombosis, and usually could be associated with poor outcomes or poorer outcomes. So, and the question at the end of the day is, if the patient, I assume, is a bacterial meningitis and receiving either antiviral or antibacterial antibiotics, then I wouldn't consider the risk that of intracerebral bleeding or hemorrhage that may outweigh the potential risk of having a complication for cerebral venous thrombosis if I don't anticoagulate the patient. Yes, you may disclose that with the family and tell them that in the context of an infection, the prognosis may be worse, and the risk of bleeding may be slightly higher, but there is no other way around.
And another
The
question
question is always think about what is the other alternative. Do you have any better alternative? Would you like to call an interventional radiologist or a surgeon to intervene someone with a meningitis? Would you like to hold anticoagulation therapy? So there are not better alternatives. You may not know what to do, but if you don't have a better alternative, you better write in the chart and have a discussion with the family and go ahead.
Yes.
That's my take, okay?
Are there any circumstances under which you think a lumbar puncture is important to the workup?
It's a great question. I think it was in the old fashion. If you read even the 2011 initial recommendations and practice management of cerebral venous thrombosis, the lumbar puncture was done to ameliorate some symptoms, but then some people identify there are some case reports that they may exacerbate the symptoms or headache because of causing intracranial hypotension. Remember, you have a intrasinus or intravenous hypertension. When you put a needle, it's not going to probably have a transtentorial herniation, but you are going to increase the difference in pressures. Probably not a good idea. And I don't do an spinal tap in patient with major cerebral venous thrombosis. The only consideration would be if you have a suspicion about the meningitis and the patient has only a transverse sinus, a small, but again, you have to push me very hard. I prefer to use empiric antibiotics in that case. But again, it will be a discussion with IV. Great question. I haven't heard the question in the era of biomarkers. Where is the place for D-dimers? I haven't heard that question. It's not in the guidelines. So what happened there? So now I'm asking you, what do you think? It's an open question. I am happy to, answer.
It's interesting you bring that up. So when I was a resident, and I was, and we were talking about cases with different, in the Boston system, I saw that one of the very senior neurologists was checking D-dimer. It clearly was an arterial case, and I think it was somebody who had received TPA. Well, that person turned out to be Walter Karashev's, and so there was an interesting discussion that was being held about, D-dimers and how useful they are for thromboembolic events. And I guess I grew up in a world where, these could be positive or negative, in these settings, but really could not be, could be too helpful, both sensitivity and specificity, particularly for cerebral venous thrombosis. And so it's interesting. So I'm glad you brought it up because it feels like it kind of just, in my mind, kind of just disappeared from the workup.
It's a great question actually, and related with the evolving of how we make a diagnosis and management of patients with cerebral venous thrombosis. It has a good negative predicted value. So if someone is having a headache and you do a D-dimer and you don't have an MRI or the CTV is going to take 3 hours, it's a good, if you have a low D-dimer, it may help. That is less likely to have a cerebral venous thrombosis. But again, remember, when I said it has to be normal. 500 to 1,000 nanograms. So that's some people quote over 750 or over 1,000 that, has a positive predictive value. But again, it's limited and non-specific. Someone with a meningitis may have an elevated D-dimer. So at the end of the day, it faded from the guidelines because it's not used practically and it doesn't alter the management of a patient. You still need some vascular or venous imaging. So that's exactly what happened. So I'm not ordering D-dimers in the emergency department anymore. And the great majority of my colleagues don't use it. Again, if you tell me that you are a telestroke center and someone is 2 hours away from a CTV and you want to make a decision, it may help. But again, you are making a decision in the blind. So you are making a decision of anticoagulation therapy with a presumed diagnosis of cerebral venous thrombosis when you only have a plain CT. So anyway.
So Gustavo, at this point, should we? I mean, are DOACs now your first line treatment for cerebral venous thrombosis, if unprovoked or even provoked? Let's say they're on OCPs.
Day number, if you tell me that I'm seeing a patient day number 7, yes. If you tell me that I'm seeing the patient that was admitted yesterday in the hospital or, and we are making the diagnosis today, so I'm talking about acute, subacute, I would start, low molecular weight heparin or heparin and fractionate, and then transition to a DOAC before discharge. Yes.
So the acuity of the case, because that raises a different question in my mind, because I think that's exactly how I would do it. I'm starting to see some that are just going with full, dose anticoagulation, let's say with Eliquis, very early on. And so that's interesting to me. Every case I start with that's acute is always unfractionated heparin.
Again, the problem, John, is, the tolerance to risk and the disclosure to the patient and their families. So the question at the end of the day is, in court, that would be very hard to defend. Why? Because you are not using, in Canada, we are bounded by whatever is a standard of care. Using a DOAC in the initial 24 hours is not a standard of care. In the United States, it's probably guideline-based and is not recommended by the guidelines. So that's a problem. I'm not saying that this is a wrong practice. I'm saying that it will be harder to defend if there is a problem. And remember, you may do wrong and patient may not complain, but you may do well and you may be appropriate. And if there is a bad outcome, patient is still going to complain. So you have to be careful about how you are going to practice and to, explain. Unless you have a different situation, argument. Suppose that someone had a, like heat syndrome. Oh, well, then you are stuck, okay, let's do it. But you are justifying that you are making that decision because of contraindications for using unfractionated heparin.
Yeah, in similar circumstances, there's been, sometimes decision making to do bolus of heparin, for certain cases of cerebral venous thrombosis in which you want to get to anticoagulation faster, maybe because of the given amount of clot burden, or the aggressiveness of the disease.
Agree, but the question at the end of the day, remember, the bolus is not a thrombolytic agent. Of course, I support the bolus, but the question is the bolus is for someone who is having cerebral venous thrombosis, who is symptomatic, but not in coma. For those who are in coma, whether you put a bolus or no bolus, actually the discussion is about more aggressive interventions rather than bolus or no bolus.
Absolutely.
But yeah.
That's great.
Question.
Anybody else have any really thank everybody who's still on the call. Anybody else have any other comments or questions? I think I see one from Farzan.
Sure. And again, I'm
Hey,
available. If you have any question, happy to answer even by email, if I may.
hey, great presentation. You mentioned D-dimer. What if you have a high suspicion for cerebral venous thrombosis or vein thrombosis? This frequently comes up in the cavernous sinuses where the radiologist says that, you know, if there's high suspicion, go ahead and treat because imaging is not good either way. And your D-dimer is elevated, would you lean towards treatment in those situations, or is there any utility in D-dimer in those situations?
Okay, it's a good question. So very important, Farsan, to clarify a few things. Number one is the patient experiencing symptoms of a cavernous sinus thrombosis, yes or no? If you don't have evidence based on symptoms, clinical evidence, and then the radiologist mentions suspicious, but is not confirming that this is, in the report. It depends on how they word the report, okay? That's important. That may guide me towards, probably if you have no other alternative vascular or venous imaging available to confirm the diagnosis, the D-dimer may be helpful. But remember, the literature and most of the guidelines for the management of cerebral venous thrombosis now try to exclude the cavernous sinus. It's a different entity, okay? Yeah, similar mechanisms in place, but it's probably a different entity, probably driven more by local pathology as a potential cause. Did I answer your question?
Yes, yes. It's just that when I've spoken with the radiologist, even with MRBs, um, even with MR orbits, they say they can't definitively ever rule out cavernous sinus thrombosis. I know why, but it's just one of those things that comes up pretty frequently.
So radiologists are very common and are usually out of the hook with no seeing patients, so it's easy for them to raise concerns. But then the clinician end up dealing with the uncertainty. So how to ameliorate uncertainty or overcome the uncertainty, and that's probably a topic for a different presentation. But again, this is a perfect example about what the issues are. So it's not enough that someone raise concern about or create uncertainty. I practice based on evidence, not evidence-based medicine. I'm talking about evidence. Show me the report. Show me whether this is occlusive and evidence. Show me if there are clinical symptomatology that is consistent with the vascular imaging, and then we can, make a decision. It depends on
Thank you
how
very
you
much.
practice. Let me ask you another question. So imagine that you are seeing someone, in a rural area that you don't have a CT. Someone who had a sudden onset of left-sided weakness and, starting with nausea, vomiting, and headache, complaint, okay? Let's say NIH is 15 with decreased level of consciousness, okay? And you are thinking about, an intracerebral hemorrhage, but you don't know. So what are you going to do? And the same scenario, this is scenario one. Same scenario is someone presented with, again, sudden onset symptoms, NIH 15, again, and you are thinking, again, no nausea and vomiting, but you are thinking about an ischemic stroke you don't have and a large stroke, and you don't have a CT scan. So you don't know if it's just an ICH or if this is, an ischemic stroke. Would you start, antiplatelet therapy? Some recommendation may be in favor, but you are blind. You don't have even a plain CT scan, okay? So it depends on where you practice. In an academic center would be absolutely inappropriate. In a rural area that is 2 hours away from a CT scan may be reasonable. So it depends on the context too. Very important.
Definitely. Thank you very much.
My pleasure. Any other question?
Thank you again for the talk. I think this question, it's regarding like final treatment for patient going home. Would you use, if you're going to use a DOAC, for patient who are like a week out and they're going home, would you use the DOAC as the AFib dosing or as the DVT dosing? Like, for example, apixaban is 10
Anticoagulation. No,
milligram
no.
for
Atrial fibrillation. No. Full dose. So I use apixaban 5 milligrams BID or rivaroxaban 20 milligrams once daily or edoxaban 60 milligrams once daily. Full dose.
And for, because apixaban, for example, for DVT dosing, they give 10 milligram BID for a week.
Okay. Well, again, we usually don't, again, and I usually follow the advice of the hematologist. Again, I haven't done that for cerebral venous thrombosis. So the dose that we use is usually 5 milligrams BID. I haven't encountered a higher dose, but again, I wouldn't be opposed if that's a recommendation supported by a hematologist. What I would not do is 2.5 BID, unless there is a contraindication, is someone over 80 that, it's, weight is 50 kilos or something like that. Did I answer your question? Would that be okay?
Yes, thank you very much. Thank you.
My pleasure. Okay. My pleasure, and thank you very much. If there is any pending question, just feel free to reach out. I provided my email if any question, okay? And thank you very much for your attention. Much appreciated. And the kind invitation.